Well, tinnitus is described as a perception of sound within the ear or the brain in the absence of any external stimulus or source of sound producing that sensation. It's fairly common. You would expect about 14 to 18% of the population. So 14 to 18 persons out of 100 persons would experience some form of tinnitus at some point in life. And many of them may have it persistent over the months and years. But in 1 to 2%, it becomes significantly distressing, disturbing, intrusive, and potentially catastrophic. Tinnitus can be described in various ways. It can firstly be described very broadly as objective or subjective tinnitus. Subjective tinnitus is what the person hears and nobody else gets to hear it. Objective tinnitus is whereby the tinnitus sound that is heard by the person is also transmitted externally out of the ear. So if you put your ear next to that person's, then it will be possible to hear that tinnitus sound. The percentage of persons experiencing objective tinnitus is very, very few and far between. And it's thought to be due to emissions within the inner ear cells, which are being heard externally. And so the vast majority of patients who come to see us or experience tinnitus are experiencing subjective tinnitus. Now, when you talk of subjective tinnitus, you could divide it into either continuous, whereby the sound is like running continuously, or intermittent, where it comes and goes. Or equally, it can be described within the intermittent versions as either rhythmic or pulsatile tinnitus. And that itself can be subdivided into pulse synchronous tinnitus or myoclonic noises, or those of somatic or body origin, creaking, etc. sounds. And they can all take the form of tinnitus when it becomes more established. So we can talk about those last three varieties in detail later on. So a vast majority of the tinnitus, which is like sounds like bells, whistles, hissing, crackling noises, or electrical sounds as described by patients, arise from the cochlea or the inner ear. And they can be due to damage to the cochlear hair cells, which are delicate cells which have brush-like endings to receive and transmit the sound energy. And damage to them can cause a short-circuited signal in the system, which goes up to the brain and is read as tinnitus. There is an equal male and female preponderance, so equal number of men and women are affected. And many of these patients are affected by what is called hyperacusis. So they are disturbed by day-to-day sounds like the cutlery or the hoover or the fire engine going by, or washing machine running. So these are sounds which will annoy them as much as a chalk on a blackboard or nails screeching on a surface would annoy us. Then there can be other reasons for this sort of tinnitus, which can be linked to wear and tear or age-related hearing loss, noise-induced damage to the cochlea, which may be happening in industry, diseases like Meniere's disease, which are inner ear diseases linked with wear and tear through balance dysfunction and balance and vestibular disorders. Certain pathologies of the middle ear, like otosclerosis, where new bone is deposited to jam the third bone of hearing, or stapes, can result in more blood supply and result in tinnitus. It can also be a manifestation of in-ear tumors, commonest of them being vestibular schwannomas, which were previously known as acoustic neuromas. These are benign swellings of the balance nerve within the inner ear canal. Other causes can be linked to anxiety, high blood pressure, and even post-traumatic stress disorders. Certain medications like aspirin, quinine, etc., can give rise to tinnitus quite readily as well, as can some antibiotics, which are needed in treating infections that can give rise to tinnitus quite easily as well. Well, it can affect them in multiple ways, and different persons present in different ways. So early onset tinnitus, which has come on suddenly, tends to make people very anxious about the source and cause of that tinnitus, unless it was caused by a specific event like a blast or a trip to a rock concert or loud noise or a bang. But if it comes on suddenly, and if they're unlucky enough to have a concomitant hearing disturbance, they really are very concerned about a few things. And the commonest questions people ask, if you ask them in detail, are they having a brain tumor? Are they going to have a stroke? Are they imagining it, and this is causing them to imagine it, and it's nothing real, and it's all in their head? So those are the three concerns mainly. And so they suffer a lot, because then they ask various people. Oftentimes it may come as, I can hear this noise, and they ask the partner, can you hear that car engine or the generator? They say there's none of that noise, and they start to worry whether they're imagining it or not. But it is important for them to be told that it is a real phenomenon. It is genuinely happening in the hearing pathway, and there's a lot that can be done about it. Long-term tinnitus, when established over months and years, results in significant amount of mental anguish, potentially anxiety and depression, either linked primarily to it or causing it. They can suffer from significant stress-related issues because of the tinnitus. Sleep disturbance is another problem, and patients find it very hard to either get to sleep or get back to sleep if they wake up at night or in the middle of the night. Lack of concentration, headaches, disturbance, mood swings, all sorts of problems are known, and it really is a very, very unpleasant position to be in. So surgery is not the first line of treatment and is not the mainstay of treatment for tinnitus. And I'll explain why in a minute. The most important tinnitus management strategy is therapy-based. In Sheffield, we've had a huge experience in tinnitus research. I've been involved in multi-million-pound projects of either oral medication or a surgical intervention or injection treatments in the middle ear space, and the results have been somewhat disappointing. The long-standing treatment options have been threefold. Firstly, an empathy-based approach to the history taking to understand the type of the tinnitus, the nature of the distress or problem that the patient is suffering, and also reassuring them that there are options to help and treat. Second element is a clear explanation of the pathophysiology or the source and origin and the nature of tinnitus, and a reassurance that the tinnitus is not related to anything sinister, which obviously will involve investigations like scans. The third important element is to explain, as in all therapy-based approaches, there is need for self-help strategies, which will be provided by the clinician and the therapist. Yes, it will almost for sure go away with intense sort of management strategies, and for which the engagement of the patient is most crucial. Um, which is why the first three things I said are important to have built up: that trust, understanding, partnership, and that engagement. Because the treatment is based on essentially creating an alternative source of sound which distracts the hearing pathway to the external source of sound instead of listening inwards where the tinnitus is located. And there are various very good apps for that, which we can provide access to, and for free mostly, and also other therapy-based approaches. Sometimes patients might even need CBT and the like. Meditation is another area which is very helpful. And these are low cost but highly effective interventions which the patients can themselves implement without the need for continuing a clinician involvement. So if the tinnitus is of early onset and a recent onset, and they um, access support, help, and advice, then the likelihood of that disappearing within another 6 months to 1 year with adequate and good quality advice, as well as them engaging in those therapy approaches, are the possibility of that disappearing is very, very high in the first year, 6 months to 1 year of time. Once it's more and more established, so for example, if one has tinnitus continuously ongoing for 3 years, 4 years or so, it becomes harder to eliminate it totally because it gets more established as triggers in the higher centers of the auditory pathway, which are located between the ear and the brain. And that does cause harder hardships and problems for the patients to manage them. Now, talking of surgical options, which you asked earlier, there are surgical options which are reserved mainly for specific conditions. Now, there are situations where the scans show a blood vessel looping around the hearing nerve, and whereby the blood vessel is rubbing against the hearing nerve within the brain. And we do run clinics which are called microvascular decompression clinics with our neurosurgical colleagues. That in itself is the best place for the person to be seen with a specialized multidisciplinary approach. And we offer delinking that what is called a neurovascular conflict. So neuronerve vascular is the blood vessel, so conflict between the nerve and the blood vessel. So disentangling that and just hitching them away so that they're not at war with each other within the tight brain space. There are other areas where you can have aberrant blood flow within the brain space. So the vein that drains half of the head comes through the ear, and it's called the sigmoid sinus because it's shaped like a S, and then it goes down into the jugular vein. Sometimes there are abnormalities there, or there can be abnormal communications called fistulas. They can be treated surgically. So those are the ones where you would think and consider surgery, but the numbers are very limited, and we kind of deal with that in a specialized environment in a multidisciplinary setting. Stress and tinnitus are intimately linked. Now, sometimes patients get upset when they go for a consultation and somebody says, you must be stressed, which is why you have tinnitus. And that is not necessarily true. But if the person has a high level of stress or anxiety and stress, then the tinnitus perception becomes higher. But there can be tinnitus completely in isolation without any stress whatsoever. The other problem is the tinnitus itself can give rise to significant amount of stress for the reasons we said earlier on, because of the fear of brain bleeds, tumors, and the fear of the unknown, and the disturbance it causes to their lifestyle and sleep. So both are intimately linked. So tinnitus itself can cause stress, and the more stressed the person is, the more the tinnitus can go up. And as the stress level goes up, it becomes harder to relax, concentrate, or sleep well. So the person becomes more tired, and the more tired they are, the more stressed they are. Which is why that whole package of empathy, reassurance, and investigation to exclude any other sinister pathology is so crucial in handling this complex condition, which is rather disturbing for people. There are other triggers known which might involve abnormal blood vessels within the neck. The blood supply to the brain goes past the ear. Once it leaves the neck, it goes right through the ear, middle ear and inner ear spaces. And if the blood vessels like the carotid artery are narrowed, or the jugular vein, both of which are major blood supply sources for the brain, have any narrowing or abnormality, then they will have a noisy blood flow which will be heard within the ear. So they can be dealt with surgically. Conditions like pregnancy, hyperthyroidism, or thyrotoxicosis, bony abnormalities whereby blood supply to the brain, to the mastoid region with it around the middle ear increases. Typically, there's a condition called fibrous dysplasia or Paget's disease that can cause significant amount of increase in tinnitus. Another condition which has been recognized only recently is called superior semicircular canal dehiscence. So each inner ear has 3 semicircular canals, one set of superior semicircular canals, one set of horizontal semicircular canals, and one set of posterior semicircular canals. Now, the superior semicircular canals are meant to be covered completely in bone to separate them out from the brain compartment. In about 1.3% of the population, which is about 1 person in 100, will have this condition where the bone is so thin that the superior semicircular canal, which is essentially a balance part of the balance organ but linked to the inner ear, is exposed to the brain above. Hence, any sound going in and out of the ear will be transmitted into the head, and it is reflected back into the inner ear. It's called what's known as a third window phenomenon. So it results in echoing sensation, it results in tinnitus, it results in an internal echo of one's own voice, and oftentimes a distortion of sound, a perpetual or persistent tinnitus, and also hyperacusis or accentuation of day-to-day sounds. So that is another completely different set of symptoms which is linked to this condition called superior semicircular canal dehiscence, or Minor syndrome, MINOR'(S) syndrome, which is named after Lloyd Minor, the surgeon who described it. That can also be treated surgically, but again, we do specialized surgery for that by plugging the 2 limbs of the superior canal, and that does work in most cases. So those are areas where other sorts of triggers are described in different types of tinnitus, requiring a different surgical or a medical or therapy-based approach.